The body can only lose so much blood. It can only compensate for so much blood loss. If you have about 15 to 30% of total blood loss, you'll see pallor and weakness. Greater than 30%, we're talking like half to a bottle of wine of blood loss, you're leading to shock. So our goal is to restore blood volume because death from shock can occur if volume is not restored. Repleting volume will restore adequate circulation. It's not, though, going to fix our oxygen carrying capacity of red blood cells. So initially, in a blood loss situation, we can replete using normal saline or a multiple electrolyte or solution like Ringer's lactate solution that kind of looks like our plasma electrolytes. This is just rapid blood volume raising up, but it's not going to correct the problem where we still don't have enough red blood cells. If we look at a transfusion of red blood cells, typically we're looking at whole blood transfusion is reserved for there's rapid and substantial blood loss. The preference is actually for a packed RBCs where you're not getting the plasma, you're not getting the white blood cells removed. You're just getting the red blood cells themselves, the packed red blood cells, to restore that oxygen carrying capacity. So you get normal saline or lactated ringers plus packed RBCs. Blood banks will carry these different types, and the shelf life for blood is only 35 days. Therefore, we're constantly needing more blood. That's why there's blood drives always. Blood groups have to be determined prior to a transfusion taking place, or else the transfusion reaction is potentially fatal. And blood typing is what determines these groups. Red blood cell membranes, we've talked a little bit about this, especially in biochem, but have different antigens on their surface. And an antigen is just anything perceived as foreign that could generate an immune response to the body. So our red blood cell antigens are agglutinogens because they promote agglutination or coming together or clotting. Um, are really important to identify prior to giving blood because a mismatch with a transfusion of blood could lead to the body having a fatal reaction, kind of essentially reacting poorly to the blood or trying to get rid of the blood. The body can see the mismatched transfused blood as not self, as foreign, and they will then agglutinate and they'll destroy the blood that was just transfused. Now, it's important to recognize humans are complex. They have at least 30 different red blood cell antigens that can help place our blood into different groups, but the ABO and RH blood groups cause the major, okay, most vigorous, most aggressive transfusion reactions. So these are the ones we type the most commonly. But there's other blood groups that can have a weaker agglutination reaction. There's some listed here. We typically don't type these unless if a patient needs multiple transfusions and we're worried about cross-reactivity. So we look at our red blood cell groups, our ABO blood groups, and they are surface antigens. They can be glycolipids or glycoproteins, and they're present on all the cells of the body, including red blood cells. The agglutinogens are the surface antigens, either A or B. O means absence of both. And the agglutinins or immunoglobulins are anti-A or anti-B. You can't necessarily be anti-O because there is just nothing there. There's nothing to be anti-to. But if you're O type blood, you shouldn't have any antigen. You shouldn't have any anti-A or anti-B. Or you shouldn't have any A or B, I should say. So we'll get into this. Based off of the presence or absence of antigens A or B on the red blood cell surface, we can start to kind of put people into these buckets of blood types. And this all starts forming around 2 months old. And by 8 to 10 years old, we are fully set in our blood type. So if someone is type A blood, they have only A antigen on their cell surfaces. If someone is type B blood, they only have B antigens. If someone is type AB blood, they have codominance, meaning they have both A and B antigens on their cells. And type O blood has neither A or B antigens. Blood can contain preformed anti-A or anti-B antibodies, and they act against transfused red blood cells with ABO antigens that are not present on a recipient's red blood cells. So when we're looking at the ABO system, the gene versus the genotype, right? So this would be like the gene versus the genotype. So if someone is O blood, they would be considered OO. If someone's A blood, they could be considered OA or AA. If someone's B blood, they could be OB or BB. And then if someone's AB blood, they would be AB blood. So here's our blood group summary. This is your blood type, the antigens present on the surface of the cell. the antibodies that that person would contain. You can see that O-type blood has antibodies to both A and B because they don't know those things, versus AB blood has no antibodies because they know both of those things. And then what blood could be received. So for type AB blood, you have all blood types can be received. They can get A blood because they have A. They can get B blood because they have B. They can get AB blood because they have AB. And they can get O blood because O has none, no antigens. Versus our O type blood can only get O blood because they can't get A blood, they would react to that. They can't get B blood, they would react to that. They can't get AB blood, they would super react to that. So they're a universal donor. And this is just showing the breakdown based off of US population, based off of the government census categories for race. And so that is where we're getting these values. And so we can see that overall, the most common type of blood kind of in all categories, if we broke this down to all different race group categories in the US, would be O blood. And so that's going to be our most common blood that we see, blood type that we see. Agglutinins are just antibodies. It's another way to say an antibody. Most of them are IgM or IgG subtypes, and they start to begin around 2 to 8 months old. They peak around 10 years old, and then they kind of slowly are less and less over time, but still exist. And they're in response to A and B antigens that they're exposed to in food or bacteria, as the initial exposure is often environmental. Another way of looking at our blood groups table showing the genotype, the blood type prevalence, the agglutinogens, and the agglutinins. So these are the antibodies. These are the antigens, AG. Now, because it's too simple, right, we got to add another factor, and that's where we get to our rhesus groups or RH groups. So our rhesus, RHESUS groups are 52 in total. Okay, these RH factors. Now, C, D, and E are the most common. If someone is Rh positive, we indicate that that is the presence of D antigen. This is actually 85% of the United States population. Our anti-Rh antibodies then are not going to be spontaneously formed in an Rh negative person because that person's never seen Rh before. Anti-Rh antibodies will form if an Rh negative person gets Rh positive blood because they've never seen Rh before. They've never seen that antigen D before, so they're going to react. An anti-Rh antibody can also form if an Rh negative mom is carrying an Rh positive fetus. Let's say that the husband was Rh positive, and so fetus is Rh positive, but mom's Rh negative. It's now never seen this antigen before that the fetus has, so it could potentially start to create antibodies towards that fetus. The second exposure to Rh positive blood would lead to a transfusion reaction. The initial exposure would not, but the second exposure could. This is where we get to hemolytic disease of the newborn. This is also called erythroblastosis fetalis. It occurs only if you have an Rh negative mom with an Rh positive fetus. You need those two factors to have this condition. In first pregnancy, an Rh negative mom is exposed to the Rh positive blood of a fetus during delivery. The first baby is born healthy. The mom, though, being exposed to Rh positive for the first time, now creates anti-Rh antibodies. Now, in the second pregnancy, the mom's anti-Rh antibodies, can cross the placenta and destroy the red blood cells of her Rh positive baby. The baby can be treated with pre-birth transfusions and exchange transfusions after birth. But the goal is we want to actually prevent this from happening. So we can administer RhoGAM serum, which contains anti-Rh, and this can prevent the Rh negative mother from becoming sensitized even from the jump. Now, again, all these transfusion reactions and things, they are rare, but they could occur only if mismatched blood is infused. The donor cells are attacked by the recipient's plasma agglutinins or antibodies. They will then agglutinate, clot together, and clog small vessels. They can rupture and lead to hemolysis. They then can release hemoglobin into the bloodstream. And the prognosis ultimately of a transfusion reaction is lower oxygen carrying capacity, which we're trying to treat typically with a transfusion, so not good, and decreased blood flow beyond the blocked vessel. Hemoglobin and kidney tubules can also lead to kidney failure. So symptoms are listed here. Treatment, the goal is to prevent kidney damage with fluids and diuretics to wash out hemoglobin. And it's really important that we match, we type and screen. You will get to blood type at least one time in your education here. We blood type typically in our second year in lab diagnosis, but you may get to blood type a few times and you'll essentially mix the blood, whether it's yours or your patient's, with antibodies against a common agglutinin or agglutinogen. If the red blood cells clump, that would be a positive reaction indicating the agglutinin is present or agglutinogen is present. The blood is typed for both ABO and RH in this way. And you would then do cross-matching between the specific donor and the recipient. You can have reactions between solid tissues and organs as well. Autografts are transplantation to self, so like skin moving from one area to the other, that's less likely to react. You could have an isograft, that's between a genetically identical donor and recipient. The mechanical attachment and blood supply would be the major issues here, not a genetic or not a reactivity per se. An allograft is between outbred individuals of the same species. You really have to do antigenic matching, and these grafts can last up to 15 years. We see these skin, kidney, heart, liver, pancreas, bone marrow, lung, etc. And then a xenograft is a graft across species. This is almost always rejected with tissue death 1 to 35 days after grafting, except for in specific conditions or with specific medications on board. Rejection of transplants, we can have hyperacute, acute, and chronic. Hyperacute is fast, within days. Acute would be within weeks, and then chronic is over time, months to years, and this is often due to T cells becoming activated against the tissue. The goal is to avoid this reaction by tissue typing, both blood type and also looking at antigens on our cells, both HLA and major histocompatibility antigens, as well as being on immunosuppressive medications for life. Our HLA antigen is encoded by our major histocompatibility complex, and that is essentially MHC here. There are 6 different classes total with over 150 antigens expressed, and these are on nucleated cells. So we'll see MHC class 1s, that is HLA A, B, or C, and MHC class 2, which would be HLA DP, DQ, DR. So consider it's a 2 if there's a D next to those letters. The goal is to find the best match among the closest relative possible. So get the closest match here as the person can. We can immunosuppress though, and we do with these different grafts, but that can lead to complications like infections, especially viral infections. Our body's tumor surveillance is decreased, so you could see more rare cancers. Glucocorticoids specifically suppress lymphoid cell growth, so you'll have less antibodies and less T cells being created. Certain lymphocyte toxins can be used, but again, they're toxic to lymphocytes. And there's also T cell specific agents, which prevent graft rejection, and they tend to leave most of the immune system intact. So they would be the best choice, but these are oftentimes they have other kind of complications or challenges. Almost there. Blood develops early on. Actually, we'll stop and we'll do blood development in our last little snippet.